Hey everyone, I'm Dorothy Poppy, the Executive Director of the Bobby Jones Chiari and Syringomyelia Foundation. And I wanted to welcome all of you to this really exciting lecture night, the Chiari Workshop for Good Vibrations, Calming the Anxious Mind. Bobby Jones CSF is proud to be a partner with the Washington University team, and I would like to thank our speakers who are here tonight for taking the time to share this valuable information with us. Also, Tonda Meehan, who is our coordinator for tonight's meeting. Dr. Jen Straley, who is our PI out at WashU, and Dr. David Limbrick, who is a long time partner with us. What I'd like to just tell you a little bit about is one or two things because we have a long program. I'm going to be very brief. So Bobby Jones promotes advocacy, awareness, education, and supports research. And this year, we are proud to say that we hosted our first patient conference in Washington, D.C. We were hoping for about 50, maybe 60 people to come. It turned out we had over 125 people show up, which was wonderful. It's a 3-day meeting where we have 1 day of research and science lectures. And then the second day we do a wellness day, which fits into what we're talking about tonight. And also train people on how to speak to go up on the Hill. And our third day is up on Capitol Hill with one voice sharing a great message. So I encourage you to look for that again next year because it was so well attended, we're going to do it again. And I just want to say one other thing. We also want to encourage anyone who needs support. We do run a virtual monthly support meeting for adults, caretakers, and young adults, meaning teenagers or college-age students who want to be mentored or supported by peers and also people who are in the medical field. So if you're into that and you need to get some support, go to the events page on our website and look through the events. You'll see the support group meetings, sign up, and you will get a link. And I'm going to turn this over right now just to Caitlin to tell one or two things about the research that we currently have going. Caitlin.
Hi. Sorry about that, guys. I advanced the slide too quickly. So yes, I just wanted to talk a little bit about the fact that we're involved in research. So our biggest current project is the Chiari Surgical Success Scale. We're collecting a lot of data at baseline and at follow-up for all our Chiari patients that are undergoing Chiari surgery. And the goal is really to develop a tool that a surgeon can use that can actually predict who will or will not do well before they even think about going into an OR. So it's a massive effort. It's involving 19 currently participating hospitals and clinics and over 60 clinical and research personnel. So it's a Herculean task. We've already enrolled more than 200 patients like the ones on this call. And I did really want to mention that this work was only possible with the partnership that we have with WashU. So thank you to the team past and present who were able to get that project off the ground. We're still collecting data, but we're pretty excited about where it's going. So if you have questions, you're very welcome to let me know. I did want to mention quickly, we're pretty dedicated to improving the lives of people with these disorders. So obviously we have our programs, research, education, advocacy, but to be truly effective, we want to make sure that it's beneficial to you. So your unique insights are being requested. We have a short survey that's going to just help us learn what's most important to you and your family, your loved ones. So it's just not just about sharing your opinion, it's really shaping the future of our programs for at least the next 5 years. So the prioritization survey is available here. There's an optional demographics survey. I recommend you take it if possible, but completing both surveys won't take more than 10 minutes. So if you can, please do. I'll put the link into the chat, but if you have questions, you can contact me directly or email research@bobbyjonescsf.org. And then just before we get started, I wanted to point out anyone who joined a little late, this was on the first slide, but WashU has some really cool stuff happening with their Chiari research. So I just wanted to point that out as well. I'll put this in the chats also. But you can take a look at their website. They have current projects that are enrolling. So just make sure you visit that. Even while you're listening to tonight's program, you might hear some stuff that's relevant to what's on that website. And so I'm going to stop sharing and I'm going to switch it over to Dr. David Limbrick, who is currently the chair of neurosurgery at Virginia Commonwealth School of Medicine in Richmond, Virginia, actually. But he was previously the head of Chiari research at WashU. So a lot of the research and insights you're going to hear tonight were really kind of directly resultant from a lot of the work that he's done. So with that, I'll just leave it with that. So Dr. Limbrick.
Thanks so much, Caitlin. First of all, I want to thank everybody on this Zoom for being here tonight. We've seen this group grow over the years, and it's just so gratifying to see it. So thank you for attending. I want to thank, first of all, Caitlin and Dorothy from Bobby Jones, and our speakers tonight, Chad Sylvester, who I see there, and Jarod, Roland, and Katie Bucklen. So thank you. We're going to hear more soon. A lot of what we're going to talk about tonight kind of was the product of or grew out of the work we did through Park Reeves in association with Bobby Jones. And we have this larger project now that's led by Tanda Meehan, who's also attending and was instrumental in coordinating this event tonight. And really, this project, which we really kind of define or we called redefining Chiari malformation, it grew out of a frustration at our lack of understanding, a fundamental understanding around Chiari. And so that's what this is tonight. It's a part of this effort to really understand the great unsolved problems associated with Chiari malformation. And, we think about those as pain first and foremost, cognition. And tonight we're going to highlight anxiety. But really, this is one of the focus areas that we're really trying to understand better. So going beyond just sort of surgery and surgical parameters, but how does this affect patients and quality of life? So I'll stop there and just say thanks again, especially to Tanda, Caitlin, and Dorothy for putting this together and for everyone who's attending tonight. Thank you.
Awesome. So with that, I actually will just have our first speaker get started. So we have Dr. Chad Sylvester, who is let me make sure I'm doing this right, child and adolescent psychiatrist at WashU. And he's going to talk a little bit more about, just anxiety and things like that. Go ahead.
Sounds good. Thank you. Hopefully I can share my slides here. Can you guys see the slides?
Perfect. Mm-hmm.
Is it just the regular view now?
Yes.
Okay. All right. Well, thank you for this invitation. I'm really honored to be talking to this group and getting the chance to talk to you all. As was introduced, I'm a child psychiatrist here at Washington University. I have a research program that focuses on differences in brain development associated with kids that go on to develop problems with anxiety. And then I have a clinic at WashU that is specifically focused on treating kids with anxiety disorders. I'm going to talk today just really generally about the types of anxiety and what it looks like in kids generally. Of course, individuals that have Chiari malformation have higher rates of anxiety, but usually the approach that we take when we're evaluating or trying to help someone is similar. And so hopefully I think this will be sort of a useful sort of foray into that. But please, anyone jump in, or I think there'll be questions in the chat because I'd like to make this helpful for people. So please feel free to divert me or ask questions along whatever way you'd like. So I always, whenever I talk to folks, I like to just start off by just making sure we're on the same page as far as definitions, because people can mean a lot of different things when they use a word like anxiety. And as a child psychiatrist, when I'm seeing a kid for the first time, I'm looking for different types of anxiety or what their anxiety looks like. And so the first thing to say is that anxiety disorders are a group of related disorders that share a few common things. Of course, there has to be like excessive fear, so being scared of something that's in front of you, or anxiety that's worrisome, like you're worrying about something in the future. And it's normal to have some level of anxiety or fear. Of course, it's an important human emotion, and so we say that it becomes a problem or it's a disorder if it's causing a problem in the person's life. And for most people, that looks like avoidance. So people tend to avoid whatever it is that they're scared of. But it can have other ways that it shows up. A lot of people will become very angry or have outbursts in situations where they're anxious, or they have a lot of distress. So they kind of grin and bear it. But these are sort of the common elements of all types of anxiety. And then the next thing that I wanted to do, and just because I think it's really important when you're thinking about someone that might have anxiety, it actually is really important to potentially think about what kind of anxiety they have. And so I'm going to talk about the 3 or 4 most common types of anxiety problems that come to clinical attention in children. And so the first is separation anxiety. So these are people that have fear whenever they are separated from a caregiver or from someone they care about, that specifically that something bad is going to happen to them or something bad is going to happen to their caregiver. So a kid might worry if they're separated from their parents that the kid's going to get kidnapped or the parent's going to get into a car accident. This can happen at home, so someone won't want to be in a room by themselves. They might not sleep in their own room, or might have a lot of nightmares, might have a problem going to school. But the theme is always that something bad is going to happen to them or to a loved one. The second type of anxiety that commonly comes to clinical attention is social anxiety. So these are situation. In this case, the fear is negative evaluation from other people. So and the most common way this comes up are then people that are shy. So they feel nervous about introducing themselves, talking to other people. But social anxiety can show in a lot of other ways as well. Um, a lot of times in sports, for example. So people that have high social anxiety, they might not want to participate in group sports or individual sports because they feel like people are watching them or judging them. Obviously, giving a presentation in front of the class or professionally or whatever it is. But again, the worry is other people are thinking something bad about me, and so it's causing me problems in at least one particular situation. And then the third type of anxiety problem that commonly comes to clinical attention is called generalized anxiety. And so these are people that are always worrying about something in the future. So the first two are more about fear. So fear of separation, fear of social situations. This is really more about anxiety. So just imagining what could go wrong in the future, and it could be anything. It could be, are we going to get someplace in time? Did I bring the right things? What's the weather going to be like? But it's future oriented and it's sort of nebulous because it can attach to anything. And a lot of times, people that are sort of caregivers or friends or parents of people with generalized anxiety find themselves constantly reassuring that person, potentially that kid, that because once they feel better about something, their worry switches to something else. So it's more about a process of worry than it is about one thing in particular. And then the other type, actually the most common type of anxiety is actually what's called specific phobia. So being scared of something in particular, and that could be fear of strangers, fear of flying, fear of heights, fear of needles, or sometimes fear of say like a medical situation. And it's the same idea as everything else that I'm going to talk about today in terms of the other 3 types of anxiety disorders. I just don't have a slide. But again, I think it's really important if you think you might have anxiety or you know someone that might have anxiety to think about which types of categories they might fall into, because it really does help us think about what's going to be useful for that person in terms of helping them and coming up with a treatment plan. A few other just kind of general educational pieces that I always like to make is anxiety is extremely common. So it's the most common form of mental health problem, and it's the most common form of mental health problem at every age. So it depends how we measure it and how we ask questions or how we go about it. This study put the rate at about 30% of people in their life experience some level of impairing anxiety. That exact number changes from study to study, but however we measure it, it's always the most common, more common than depression, ADHD, or certainly more rare things. And even more so if for people that have other psychiatric or medical health problems. And so the numbers would be even higher for people that have other kinds of, again, medical problems. So lots of people are struggling with anxiety. The next point that I like to make is that for most people that have a problem with anxiety, it starts when they're very young. So the median age of onset of an anxiety disorder is about 6 to 8 years of age. So that means that half of all people that in their life will ever have a problem with anxiety had that problem or had a problem with anxiety by the time they were about 8. So just to say that if you are seeing someone that is that young that has anxiety, it's common because that's often when it starts, and then it can be persistent or take other forms as the person gets older. So the exact type of anxiety that a person has may switch. So when they're younger, they may have separation anxiety, and then social phobia as they get a little bit older, and then maybe generalized anxiety as they become an adult, or they may get different specific phobias. So the exact manifestation may change, but the idea is that for most people, it starts very young. And so that makes us think that whatever it is probably something that's happening with the brain from a very young age. And in fact, even before 6 or 8 years of age, we can see symptoms in 1 and 2 and 3-year-olds that aren't perfect, but they help us predict a little bit who's likely to have a problem with anxiety later in life. Because those infants are more shy, or they get really sort of startled or activated by something that's new or different. If they see a stranger, if they get put into a new room or something like that. And even those early warning signs when you're very young are predictive of later anxiety. So again, seems to be some early neurodevelopmental thing that predisposes people towards anxiety. The next point that I want to make is that for most people that have a problem with anxiety, it's persistent. That is that they pretty much always have some level of symptoms of anxiety. Certainly it can get worse in certain situations, like if they are going to go into that situation, they usually should get nervous in that situation. And that's different from other kinds of mental health problems that we treat as psychiatrists. So things like depression, which is also a very common mental health problem, is what we call episodic. So people with depression, they will have a week, a couple weeks, months where they're very sad, or they don't enjoy things as much as normal, or they're really irritable, or have other sorts of changes in their mood. And those mood problems can be very problematic. But for many people, they'll have episodes that will last that time, and then it could go all the way just all on its own for months or years, and then come back again. So other mental health problems can kind of have this ebb and flow, but anxiety tends to be more persistent. And the reason that I bring that up is that for people that like suddenly have anxiety that they never had before, we want to make sure that there's not something else going on, that there's not a stressor, that the person isn't being bullied or has some other interpersonal problem, something is going on at home, that then you'd suddenly see the increase in the symptoms. Okay, so those are the general points that I like to make, and then the other thing that I like to remind people or let people know is that for most people that have anxiety, or for many people that have anxiety, it's also common that they might have another mental health problem like ADHD or depression or something. So anytime we see a kid or someone with one of those with an anxiety problem, we also want to see if something else like that is going on. And then, although most kids that have a problem with anxiety, although most of them do really well when they're adults, a kid that has a problem with anxiety is more likely than their peers to have a problem with depression, substance use problems, or other mental health problems when they're an adult. So what we hope is that if we can help people at all ages, right, or when they're young, is that maybe we can help prevent some of that other stuff that might come later on. Okay, so now I want to sort of just very briefly go over what we do to help people with anxiety, and I'm going to focus on kids here, but the evidence is the same for adults. So I'm also I spend most of my time doing research studies, again, studying brain development with anxiety. So I always go back to the science to try to help figure out how I can help my patients. And I'm not going to go into the details of the study, but the results of how to help people that have a clinically significant anxiety, and that's true. We have less evidence for people that have other neurological problems, say, but by and large, these same results hold up. And that is that medicine and therapy are both effective for people with anxiety. And they're better than it's like a sugar pill or doing nothing. So in this study that I'm showing here, kids that were started on just a medicine or just had therapy were doing better. 60% were doing better 3 months later. And that was better than the 25% of kids were doing better that got no treatment. But then the combination is better than either one alone. So medicine plus therapy is more effective than just getting medicine or just getting therapy. And in this study and many other studies, therapy and medicine appear to be about equally effective. I'm not going to go into the details of the method that we typically use unless people sort of want to ask a question about that. I don't know how useful that would be, but typically these are medicines like SSRIs, the medicines that you take once a day and that you show symptom improvement over weeks and months rather than medicines that immediately make the anxiety go away, like a benzodiazepine or something. So I know there's going to be another sort of talk that goes into detail about some ways in which the anxiety can be managed therapeutically. But I just want to emphasize that therapy is extremely important for people with anxiety. And there's lots of different types of therapy that you can get. So saying that you're getting therapy is sort of the same as saying you're getting a medicine, which means it's not very specific. There are different recipes that the therapist is following. And there's many different approaches, but at least in the kids that I see, the most the most research points towards using what's called cognitive behavioral therapy with exposure, CBT with exposure as having, again, just the most evidence, the most number of studies that support it. And so for people that are at the point where they feel like they want to get help for themselves or for somebody else with anxiety and they want to go a therapeutic route, I always recommend that they specifically ask whether or not the person does CBT, and again, especially with the exposure part. So again, I'm just going to just briefly touch on this because I know there's going to be a longer discussion, but the idea behind exposure therapy is that whatever it is that makes the person anxious or scared, and this is why it's important to know if they have separation anxiety or social phobia or some specific phobia. The idea is to find how like scary things seem to them on a scale of 1 to 10 and find different situations that sort of make them a little bit nervous or moderate level of nervous or very high levels of anxiety, and then gradually have the person intentionally put themselves into those situations, but starting with the easy stuff, the ones and the twos, and then week to week, sort of building up to the higher stuff. And this can also be true for more specific phobias like fear of doctors or needles or something like that, where you can gradually get the person there in sort of a behavioral way. And so tends to be really important for people with anxiety. Okay, I'm not going to spend, again, a lot of time on this slide because, again, there's going to be another talk about this, but it's just sort of emphasizing that a way to help a person with anxiety is sort of building off of what we do in therapy, which is getting them to be sort of mindful, as we'll hear about, in terms of their thoughts, feelings, and body sensations when they're having these anxious, and then seeing if you can come up with a way of gradually exposing them to whatever it is that makes them anxious. All right, and then it'd be remiss if I didn't say that, again, we always want to understand everything that's going on in a person's life. So if we're trying to help someone with anxiety, we also want to think about other medical problems that the person has, other psychiatric problems, how everybody else around them is doing. So if a parent is struggling, it's really hard for us to help a kid get better. Stressors that are happening at home or with peers are really important. So if someone's being bullied and they don't want to go to school, that's not an anxiety disorder. That's just being scared of an actual threat. Okay. And then I was asked to also talk a little bit about some of the research that we do. So I'm just going to kind of briefly give sort of a high level view of some of the work that we've done. This is how I spend most of my time. So I think about sort of brain function at the level of what's called a network, which are just like large parts of the brain that are working together to do something specific. So in this slide here on the left here, I'm working on something. And so there's a lot of activity in a network that is called the frontal parietal network, but it just helps me pay attention to what it is that I want to pay attention to. And then this person in the next slide, this person is calling my name. So I redirect my attention towards him. And a different set of brain regions then have higher activity. In this case, it's the ventral attention network. So you need this other network to sort of suddenly change your attention if something happens, like your name gets called, or an alarm goes off, or there's some other salient thing that you need to respond to. And so it's what your focus of attention is sort of a balance between these brain networks that are involved in directing your attention where you want to, but then also being able to shift your attention if something comes up that you need to pay attention to that you weren't thinking about before. And so my lab has done, amongst other things, some work looking at these sort of how attention works in people that are anxious and how these brain systems work in kids that are anxious. And what we've found is that adults and kids that are anxious and that have these anxiety disorders that I mentioned earlier, they have sort of a overactive ventral attention network. That is, their attention is more readily shifted or more quickly shifted to things that are unexpected or different. So like if a loud noise goes off or there's a flash or something. So we think that maybe part of the challenge and maybe part of the reason why someone is anxious is because there's a disbalance between how their attention is focused. So it's harder for them to just stay locked in on what they're doing and instead get shifted to something that then they might interpret as scary or wrong or bad in some way. And so in this study, we just showed that the more anxious a kid was, the higher activity they had in this brain network, the teal here, the ventral attention network, that redirects your attention to things that are unexpected or different. And I don't want to make too much out of this, but just to kind of show you the direction that we're trying to take some of this work is seeing if we can then help the person by maybe correcting this difference, by retraining their attention or by retraining this brain network. So decreasing the amount of activity that happens in this brain network when something unexpected or different happens, so that the person can stay locked in on what they're doing and not get distracted by things that then they're going to potentially think of as scary. So the details here aren't super important, but we came up with this sort of simple computer game that kids could play for about a half an hour a day, twice a week for a month, where they had to pay attention to a part of the screen based on where this arrow was pointing. And eventually they were going to just have to make a simple decision about something that happened wherever they were paying attention. But they had to ignore, while they were doing that, they had to ignore all these other things that were happening on the screen and hold their attention at that one place so that they could be accurate when they had to make a decision about something that appeared there. And so the idea was by just practicing paying attention, right, in one spot and learning to have to ignore all this other stuff that was going on. And in fact, they had to keep their eyes in the middle of the screen. So if they moved their eyes and looked at anything, the screen went blank and they had to start over. So they really had to learn how to stay focused on something and ignore something else. And so this was an early study. We only had 18 kids in this. There was no control. They were coming into our lab, so they expected that they would get better. But we had them do this. We found that their brain activity in this network that we thought was problematic, the ventral attention network, went down. So we feel like we changed their attention and we changed the activity in their brain. And then their anxiety got dramatically better over the course of the training, especially early on. Again, I don't want to make too much of a big deal out of this because it's not a controlled study. So I wouldn't recommend that people get this right now. I think it's better to do therapy and medicine, the tried and true stuff. But just to give you all a sense of the type of work that we're doing, how we're trying to understand how the brain might be functioning differently in kids and adults that have anxiety, and then how we can actually leverage that into new treatments. So I will stop there. And it was like sort of a very quick version of sort of the discussions that I normally lead. So definitely happy to clarify anything or on any of the stuff if it's useful.
Excellent. I think we can take a couple of questions, if there are any. I know I have one to start us off, if anything. So you mentioned, the differences between social anxiety and generalized anxiety. I guess a good question especially for parents, is how do you identify that in a child necessarily? What's the difference between, anxiety versus typical distraction, or just actual fear of something? And then what does it look like? And then when do you recommend seeing a professional as opposed to managing it on your own?
Yeah, those are great questions. So, I'll take the last one maybe first. So, as far as when do you think it's when should you get help or when should you do something? I don't think it's super important to create a magic line and say you have you have a disorder or you don't. I mean, sometimes we have to do that for practical reasons, but I think that if the simple answer is if it's getting in your way in some way. So if the child doesn't have as many friends as they'd like, if they aren't participating as many sports as they would like to, if they're not going to school, or if they're distressed a lot, if it's causing any sort of way where it's getting in their way, then it's at least worth doing something. And that might be talking to your pediatrician, that might be working with a therapist, or that might be something even just more simple like following some of the tenets that I had on that other slide, or getting a book about helping your kid with anxiety. Because a lot of the therapeutic interventions or the simple things you can do, like the gradual exposure, are going to be helpful no matter what, right? No matter what level of anxiety the person has and whether or not they go into a disorder. As far as knowing sort of what type of a problem that a kid might have, if there's any question, it makes sense to talk to a professional that can sort of direct the conversations that would help get at that, because it sometimes can be difficult. You brought up at the end sort of being distracted, right? So sometimes kids that have ADHD and have anxiety, sometimes it can get really complicated to know if, say, they're nervous about taking a test because they have performance anxiety or social anxiety versus they're not very focused and just in general. And so usually what we're doing is we're looking for patterns across multiple different environments where the same types of problems are coming up, because then we think, okay, then it's probably falling more into this category than another. So I don't know if that answers all of your questions. It's something that we usually just take a lot of time and try to sort through.
Yeah, it's pretty heavy loaded. Sorry about that. And I'm gonna preemptively ask this one because I know I get this a lot. As far as the medications are concerned, I know a lot of parents have a lot of, hesitancy, I guess, because they're a little worried about, short versus long-term effects of SSRIs, things like that. So is there anything that you would say to their, efficacy and safety and all that?
Yeah. So SSRIs, right? So the category that we use they're very effective for children with anxiety disorders. They and I showed in the previous slide, but there's a lot of work to suggest that they're equally effective as therapy. At least in the studies that they use both of them. Most kids tolerate the class that we use without any side effects. The most common side effect would be sort of a little bit of maybe sick to your stomach or a little bit of headache when you first start the medicine. It's relatively rare for kids to have long-term side effects from SSRIs. And if it happens, you can just stop the medicine it goes away. In fact, in meta-analyses, the only thing that's more common than a sugar pill, specifically for kids that have a problem with anxiety, is something called activation, which is just like a kind of like a rambunctious energy that can be too much. There's a black box warning on SSRIs for kids for increased thinking about suicide, which sometimes come up. So first of all, has never been shown in kids that only have a problem with anxiety. Those were studies that included kids with depression, which is a separate thing. And then the data from some of those studies were that there were very low rates overall of thinking about suicide, and there was never any actual suicide attempt or completed suicide or anything like that. So SSRIs are a very safe, can be very efficacious medicine. Obviously, you should talk with your physician, about this because everybody is different. And the other thing I like to, flip a little bit on its head is that, the studies that we have when kids are treated for their anxiety, their brains look more sort of like typical, we'll say, or more like kids that don't have anxiety after treatment, and that, including with SSRIs. We also know that kids with anxiety can have a lot of problems if it's severe, right? They can have other mental health problems later on. They can be less likely to get a job. They can be less likely to have meaningful peer relationships. So all this just to say is it's not benign to grow up with anxiety your whole life. Like there's also a risk of having anxiety and not having it treated. So it's not really just what are the risks and benefits of taking the medicine or not taking it. It's what's the risks and benefits of taking the medicine and potentially having your anxiety better versus not taking a medicine and maybe it doesn't get better, or what the other options are. So it's an important question, and a long one, but obviously I feel pretty strongly that these medicines help a lot of people.
Absolutely. And we do have time for one more. It just came through. So this is a question perfect for you, actually, because it's in the scientific realm. Or maybe we could do one more. We'll see. Patients who have difficulty metabolizing these types of medications. So what would you recommend for alternative options? This person mentions stabilizing microglia. I'm not sure how that would work, but what are the alternatives to medications if they're not necessarily tolerating the medicine, I guess, for lack of a better.
Yeah, it's a great question, and there's a lot to unpack there, many different facets of this. I mean, we sometimes, if we have a kid that will have a hard time with several medications, we can send out a genetic panel, which will tell us, at least give us some information about which medicines the person may metabolize better or worse. And then that be based on the enzymes in their liver and what their liver breaks down. And so that can help us sort of like either find a medicine that they do metabolize okay, or potentially adjust the dose based on what the results are saying. And it can go either way. You can be a fast or slow metabolizer. As far as, I mean, obviously there are other non-medicine treatments for anxiety, which again are very important. Medicines and therapy are equally effective. So therapy is a very good option for everyone, including people that can't tolerate medicines. As far as other options, other types of medicines, there are studies out there that show some initial evidence for things like that, but it's early on, and sometimes you see big results like that hold up, and other times you don't. And so I'm reluctant to sort of wholeheartedly endorse anything else. There have been negative studies of something called like Buspar or Buspirone, which is a medicine that's used to treat adults with anxiety. That the benzodiazepines like Valium or Xanax or something actually can make kids more likely to have depression. So unfortunately, we can't just always take medicines that work in adults and apply them to kids. And so those are the main medicines, are SSRIs and then SNRIs, which would be like duloxetine, Cymbalta, venlafaxine, Effexor, things like that, are the two main classes that have been well studied in kids. So
I'm going to squeeze one more in really quickly, just because it's pertinent specifically to medical and like health anxiety. So you talked about CBT medications and exposure therapy, but any ideas on different paths to help if, typical treatments aren't working necessarily and they still have all that fear, and you don't necessarily want to, put them in an MRI or make them go to the ER. So how do you handle that when it seems to be persistent?
I mean, that's tricky. And obviously this is a situation where you would want to develop a relationship with a therapist or someone, another provider that can really dig in what specifically is happening in those situations. But I do think that, you can get pretty creative with exposures because now we have YouTube, so you can watch a video of all sorts of things. Or, I do MRIs in kids. So we use MRI to study brain development in kids. We have lots of kids that are nervous about getting an MRI. We have a mock scanner setup where they get in like this, essentially like this cardboard tube, and we play loud noises and do other sorts of things. So it might be hard to do those things, and you have to decide if it's worth it, right? Because it depends on how often they're going to get an MRI. Like if it's going to happen once every 5 years, then that might be a case where you just give the person something to calm them down immediately because it's like a one-off acute situation. But if it's something that they're going to be doing regularly, like if they're going to be going to the ER a lot or MRIs a lot, then it might be worth trying to think creatively with a therapist about exposures.
Awesome. Thank you so much, Professor. I'm going to bring up our next speaker, Dr. Jarod Roland. He is a neurosurgeon at WashU. If I'm not incorrect. Yes, I'm correct. And I'm really excited to hear his talk. And you should be able to share, so go right ahead.
Perfect. Thank you. Can you hear me okay?
Yes.
Perfect. Let's see, I'm starting to share my screen here. Make sure that's coming up. Okay. Well, very good. Thank you for that. And thank you for inviting me. Thank you, Chad, for that awesome talk. I'm going to walk through a few things that we're working on one of our research studies here at WashU. Some of it relates to some of the things that Dr. Sylvester was talking about kind of towards the end of his talk there. I'll try to tie things in just a little bit. And this isn't a lot of finalized analysis. This isn't things that are published yet. This is kind of interim analysis, but some of the kind of progress that we're making. If you've heard some of our talks before, you've heard us talk about this ongoing study that we have called the Redefining Chiari study. It's something that you've heard us talk about even earlier today, where we feel like the definitions and some of the things that we describe when we talk about Chiari malformations are potentially long overdue for being redefined, hence the kind of overall arching goal and name of the study. You'll sometimes hear me talk about Project 2. I apologize if I slip that in there every now and then because it's kind of common for me to say that, but most other people have no idea what Project 2 versus 1 versus 3 is. But one of the reasons why I mentioned that is of the many projects within this overarching Redefining Chiari study, the particular one I'm talking about today is how we're using some of this resting state functional connectivity. This is some of the resting state fMRI that Dr. Sylvester just briefly talked about, and how we're studying the effects that Chiari malformation has on these networks. So I'll step through this somewhat quickly. This are some disclosures, kind of routine grant funding and things like that. And give a little bit of background. Dr. Sylvester mentioned this earlier, but just a quick overview for anybody who hasn't heard this before about what resting state fMRI is. Sometimes we differentiate this from what is kind of typical fMRI, or what we'll sometimes call task-based fMRI, where somebody might be sitting in an MRI scanner and that scanner is watching we'll say activity of the brain while they're doing some kind of task. What was discovered years ago was that in between these tasks, the brain is active at rest, where previously that activity was thought to be kind of background noise and was regressed out of the analysis. Somebody really smart figured out that there is some structure and there's some meaning to that. The way that was initially done is a classic task-based fMRI, where somebody's sitting in an MRI scanner and they're opening and closing their hand. And by watching that activity, you could say, here is the area of the brain that's responsible for opening and closing your hand. That was the task that was being done, and that was the kind of correlation that was determined. What somebody did is, in between those periods of moving their hand, when a participant is sitting in the scanner at rest, they analyzed those signals from the different areas of the brain, more specifically that area of the right hand and the left hand. And even though they weren't moving their hands at that time, they saw that those signals were strongly correlated in time. And as you did that in multiple areas of the brain, you saw that various areas of the brain that were participating or responsible for some kind of common activities, some common cognition, some common tasks maybe, were correlated in time. And so that's kind of what we have on the screen here. As you can see, two circles, we'll call these regions of interest. And these blue circles have a tracing over time. That's what the figure is on the right. This bold change, the bold signal is that correlate of brain activity. And you can see it kind of goes up and down over time. And you see these two areas of the brain have a really strong correlation. When one's going up, the other one's going up. When one's going down, the other one's going down. And this is what we call functional connectivity, or one definition of functional connectivity. It's these two areas of the brain that are seemingly disparate in space, but related in function. These two specific areas make up what's become known as the default mode network. This was a really interesting network in the brain that really wasn't even considered before some of this type of imaging. And there's a variety of different ways to define these networks. This kind of table over here on the left is kind of an example of that. This is a small subset of the many different ways you can divide up the networks in the brain. But over here on the right is one of these we'll call parcellations, the way of dividing up these networks that a lot of us here, particularly at WashU, use pretty frequently. You might recognize this figure looking very similar to the one Dr. Sylvester showed earlier, because it's a very similar network. I believe parcellation, I believe it's the one he used. But this is one way of dividing up all of these networks. And this big red region here, this is what we call the default mode network. These represent those blue circles we saw on the previous screen. It turns out when you divide up all these networks, there's different ways of naming these things, and some of these names have changed over time, actually. For instance, this one that's called singular percolator network, there was a recent paper saying that that should probably be called the action mode network to differentiate it from the default mode network. So this is a topic of ongoing discussion. But the big picture, the take-home message is these are the ways that we divide up the brain, calling them into different networks to help understand how these different regions of the brain are functionally related. Here's a little bit of a summary graph. This is way too much to read, but it's the kind of thing where if I just kind of reference you this reference down the bottom left by Ben Seitzman and others, it was kind of a brief overview, kind of high-level picture of what a lot of these different networks represent. One of the things that we wanted to do was analyze how some of these networks might be affected in individuals who have a Chiari malformation. What we did first was we looked at a large study that's already been published where a lot of data has been shared, and that we happened to identify a subset of individuals who had a Chiari malformation in the study. What this was is what's called the ABCD study, the Adolescent Brain Cognitive Development Study. It's a really great study. It's ongoing. It started several years ago and enrolled just shy of 12,000, a little over 11,000 kids between 9 and 10 years of age. Got a lot of data on them, tons of questionnaires, and a lot of resting state fMRI data. And the really cool thing about this is it's been funded by the National Suicide Health is they release this data periodically as it's been collected, curated, and processed. They release it for other researchers like us to analyze. One of the really cool things that was done is part of what we call safety reads, while the radiologists who were reading these MRIs as they were being done, making sure there wasn't something unexpected like a brain tumor or something else that might have shown up there that an individual would want to or need to know about. They were wise enough to keep track of incidental findings. And so they noticed that there was about 71 individuals in this data set that had what they called a Chiari malformation. I'm not going to go into exactly how they defined that. There's some nuance there. But it led to a really great opportunity for us to take a look at this data and see if we could find some effects of a Chiari malformation in what's essentially incidentally found or subclinical Chiari malformation in this cohort. And because we have such a large comparison group to compare to, we can do some really interesting analysis from that control group. So we did that. We applied what's known as this Gordon parcellation. It defines 11 resting state networks and divides up those networks into parcels. So for each network, there's more than one parcel. There's about 333 parcels in the cerebral cortex. I like to emphasize that because I find it interesting that we are analyzing how this malformation, Chiari malformation, how this malformation in the cerebellum affects the networks in the cerebrum. Some people think that's interesting. Some people think it's unusual, but we think it's really important that this hindbrain malformation, this tonsillar ectopia that defines a Chiari malformation, probably has significant impacts on our cognition, certainly within the cerebellum and beyond. For this particular analysis, we were focused just on the cerebrum, not looking at the cerebellum, but looking at those cognitive networks. We analyzed 55 of those 71 individuals who were identified with Chiari malformation due to some of the data analysis issues. Not all 71 were available to us. And we selected about 2,000 individuals separate from those with Chiari malformation as a control group to compare to. So when we did that, we looked at all those different networks. And I have a graph like this for all the different networks, but I'm kind of going to skip through a few and kind of point to a few of what we think are potentially relevant. Some of them had pretty significant effect sizes. So this is the singular opercular network. When we looked at the Chiari group compared to the control group, that's what the figure is over here on the left. You can see significantly lower functional connectivity within that network. So how all those parcels within the singular opercular network were functionally connected to other parcels within the singular opercular network. That Chiari group is on the left and that control group is on the right. And again, you don't have to necessarily look at all these numbers. One of the numbers that's kind of a take-home message is this Cohen's d kind of effect size at the bottom. It generally ranges from 0 to 1, and something on the order of 0.45 is actually a pretty large effect size. But again, the number itself isn't entirely relevant other than to give you a sense of scale or magnitude. So it was a singular opercular network that was pretty significant. The default mode network, again, turns out to be highly relevant in a lot of neurological disorders. And we think is probably pretty important for a Chiari population just because of its role in things like attention or other kind of processing. The dorsal attention network, the frontal parietal network, this is one that Dr. Sylvester was mentioning as well. Again, another one that we think is probably really important in our Chiari population just because of the higher order cognitive symptoms that we hear a lot of our patients tell us about. And the type of cognitive function that's been most attributed to the frontal parietal network seem to have a lot of overlap. So kind of both the DMN, the default mode network, and the FPN, the frontal parietal network, were two of our really a priori hypotheses of what we thought was going to be most affected. And again, this kind of 0.34 is a pretty significant effect size. I'm going to skip through a lot of these just because I went through every single network kind of showing them. I put them all in here just for kind of completeness sake. This is one to show, well, not everything was affected. The sensory motor network can be divided into actually a lot of different ways. One of the biggest divisions is kind of a lateral medial or a hand or mouth version of it. And that network wasn't really affected compared to control groups. The ventral attention network, that was, I believe that was the other one that Dr. Sylvester, I apologize, I had mentioned, again, a pretty significant effect size there, showing some big changes. This is when you looked at those effect sizes, just kind of one big graph. We try to use similar color scales, particularly if you're using this Gordon network, so that the colors in Dr. Sylvester's slides are very similar to these. But you can see how this ventral attention network, this default mode network, and this central singular opercular network were some of the larger ones affected. This kind of RTP in the middle is probably a little bit less important, even though it stands out as the largest. It's not one that we're really going to focus on for a few kind of technical reasons. But this was kind of that initial analysis. What's really interesting about the ABCD study is that this is the analysis from what we call the baseline data, the year one, when all these individuals at 9 to 10 years of age. We're now several years into the ABCD study, and the subsequent timelines have been released. So we're going to repeat this analysis not at baseline, but repeat it at baseline and the subsequent time points to make sure it holds up, to make sure it's not a kind of a fluke thing that happened at the baseline, but wasn't repeated over multiple years, to make sure it is truly an effect that's related to the Chiari malformation. And what's probably more impactful is that we have designed our redefining Chiari study to match the data collection in the ABCD study. So what we're doing is we're collecting similar types of data, the exact same sequences that were done in the ABCD study in our patients who come to St. Louis Children's Hospital or Barge's Hospital, come to WashU with a Chiari malformation, and who were kind enough to participate in our research study. And we're analyzing in a very similar way. We're getting very similar NIH toolbox type questionnaires. We're also getting some more things that weren't included in the ABCD study, or things that have been previously validated for Chiari malformations to dig in a little bit more detail, things specific to the Chiari study, or sorry, to Chiari patients. Because the ABCD study, that wasn't the goal, right? They were kind of analyzing a broad range of things. And the fact that several individuals had a Chiari malformation was essentially an incidental finding that wasn't planned. So we're going to be repeating that in our data. We've have 55 individuals at least in the ABCD study. There's potentially 71, just depending on a few data quality issues. We've enrolled already over 80 from our study alone, and we're aiming for about 150 by the time of the end of that study. And we're going to replicate this analysis and find out what kind of things are truly related to Chiari malformations, which ones are robust to the type of imaging or the setting that it was done, and potentially even robust to age. Because again, this ABCD data set that I just showed was very, very uniform. All these kids were 9 to 10 years of age. We'll repeat that over time as they age throughout the study and hopefully show that it's robust to their age, or maybe even find things that change over the course of their aging. And then for our patients, they're not incidentally found or subclinical patients. These are the individuals who are coming to us for treatment, and we're obtaining imaging along the way. There'll be a subset of those who are clinical patients who might even have surgery or Chiari decompressions, those posterior fossa decompressions with or without duroplasty. And we're going to repeat that imaging after to see how some of these networks might change with treatment, hopefully for the better. Hopefully, as those individuals have some improvement from treatment, we'll see how these networks may or may not be affected. We think that this is going to provide us a lot of insights into the both mechanism of the disease, but also to help us prognosticate things. As a lot of people on the call probably know, one of the challenges for us is figuring out which of these symptoms are directly attributable to this tonsillar ectopia and which ones can benefit from intervention. The current standard kind of anatomic imaging doesn't provide us those answers. So we're hoping some of this advanced imaging, some of these functional connectivity metrics might provide us better insights to help patients in the future. So I want to thank everybody. That was a really quick kind of whirlwind breeze through what we're doing, kind of what we've done so far and some of the data that's available to us, what we've collected so far, and how we're going to be applying that to the data that continues to be collected. We have a huge team in the Redefining Chiari study, and obviously none of this could be done without those individuals who come to us for treatment and are kind enough to volunteer their time and brains for our fMRI studies.
Thank you, Dr. Roland. That was awesome. I have 1,000 questions, but I am really glad actually that I waited to ask this one for your presentation because I think it's hyper relevant. There was a question about why anxiety might be so prevalent in patients with Chiari. So could you maybe speak a little bit to the network that you found that might be kind of explaining that connection there?
Yeah, that's a great question. Might even be worth bouncing this off of Dr. Sylvester as well, because which network is most relevant to anxiety is probably an open-ended question, or maybe incompletely answered question. Dr. Sylvester might know this a little bit better than I do. And that is one of the challenges with this kind of resting state network approach is it's fairly young. It's had a ton of investigation over the years, so we're learning more and more about it. But it's actively evolving. Like I said, some of these networks are kind of being renamed. Some of them are being divided up. There's a little bit of controversy between what you call a salience network or a singular opercular network, or some people calling it action mode network. Other people call it the language network. And how you parcelate these things can be challenging. And it turns out how you parcelate them when you're doing your analysis probably impacts the results that you find. So it's challenging is a short answer. Which network might be the most relevant to anxiety? I might kick that one over to Dr. Sylvester because he'll probably know it a little bit better than I do.
Dr. Sylvester, do you want to comment? If not, it's fine.
I probably surprised him to
yeah. Asking him difficult questions.
Yeah.
No worries.
Caitlin, you need to unmute him.
Oh, no. Okay, hold on one second.
Can you guys hear me okay?
Yes, yes.
Yes, I totally agree with Dr. Roland. I think it's an open question, which parts of the brain, which networks are going to be most relevant. The only thing I would add is that, again, anxiety is the most common mental health problem in anybody. So it's already very common. And it does seem like anything where the brain is more stressed then increases that risk. So for example, kids that are born preterm, prematurely, they have increased rates of other sorts of mental health problems, but especially anxiety, right? And so I think that it's probably that anything that has additional stress on the brain is going to be likely to increase rates of anxiety in a non-specific way.
Excellent. So I'm going to ask this one. So you talked about you're doing this with your clinical cases as well, and that kind of opens the question because, you know, incidental Chiari doesn't necessarily have symptoms. So are you going to be able to then compare your clinical cases, particularly your surgical cases, with those incidental ABCD findings and the controls and see if there's any changes in between those groups as well?
Yeah, that's exactly right. One of the benefits of the ABCD, because it's such a large study, so many individuals, over 11,000, and they're doing it longitudinally. So what that means is over time, we'll have samples from 9 years of age all the way up to, I think, 20 years of age, if I remember correctly. And so we'll be able to age match a significant portion of our clinical cohort. There's a few other things that you could potentially match on. Gender and a variety of other things are probably important, but trying to match those things up as close as possible and compare them will be really important for us. One of the things that we won't be able to do quite so well is dig into some of the symptoms that are most relevant to individuals with Chiari malformation in the ABCD study, because that just wasn't what it was designed to do. There are some questionnaires, like I think it's something relatively simple, like do you have headache? But doesn't dive into what kind of headache that is. You know, is it posterior or holocephalic or band-like, or all those different types of ways headaches can present, and nuanced and probably relevant to individual Chiari, just weren't part of the design of the ABC study, understandably so. But in some of the things that we do for the redefined Chiari, we do dive into those details. So those things we won't be able to compare, but certainly some of the resting state fMRI metrics we will. Part of the redefining Chiari study also is, and again, most of the people on the call know this, not everybody who presents clinically with a Chiari malformation needs or will benefit from a surgery. So part of the RC study is we expect certain individuals to get a surgery, and some will be kind of monitored non-surgically. And we're going to get longitudinal imaging in both of those groups. And so that'll kind of serve as a control group as well, as we compare the before and after surgery to those who are clinically presenting longitudinally, but maybe didn't get surgery, to hopefully see how intervention might change some of those networks. And so that'll help us hopefully validate some of the things that we see in the ABCD, or maybe rule things out as maybe metrics of non-interest.
Awesome. And then I'm going to squeeze one more question in, and then we're going to get our last speaker. So we're talking about anxiety and stuff like that, but the connection with, you know, agitation, irritability, I don't know if that's something that either you or Dr. Sylvester can speak to about those connections there, and then what you found, how that might be impacting that kind of issue as well.
Yeah, I don't have any findings on this one right now, but it does recall one of the prior talks we had about this this idea of pathologic itch, some of that kind of activation that happens, and that's something that's been one of these things that has come up as we've learned more and more about our Chiari malformation symptoms. And it comes up from meetings like this, where we hear from patients, sometimes outside of the clinic, in some of these groups, where individuals can talk to each other and say what they experience, and somebody else says, yeah, I experienced that too. It's like, yeah, I experienced that too, and I didn't even know to mention it. And that's one of those that kind of comes up and it relates to that aspect. Sometimes it's a similar concept, but manifests in different ways. And that's one of the challenges of defining all these things is, and I'm so glad that this is what Dr. Sylvester started off his talk about, of how you define anxiety, because otherwise it gets really confusing about what we're talking about, and what one person describes as irritation, somebody might describe as activation, and somebody else might describe as a pathologic itch. But those are really important concepts that are very nuanced, but require a high level of scrutiny to be able to tease apart.
Okay. I don't know if Dr. Sylvester wants to comment, but in the meantime, I do want to get oh, go ahead.
I can. I mean,
Yeah.
I agree with everything Dr. Roland said. I mean, it's tricky when people come in with specifically about agitation or being upset or suddenly angry or irritated in different situations. It's another situation where it's really important to figure out exactly what's going on, like what's triggering it, what are the situations in which it's arising, because it can happen from an anxiety problem, but it can also happen from ADHD. It can happen from just general dysregulations of mood, where mood is just more labile and regardless of what the situation is. And so that's why it's another reason why I do think it's important, if you're thinking it's anxiety, to really think if it falls into a category that cleanly hits into anxiety about one thing in particular, about a category of things, because it does change sort of even the medicine that we would use if we're trying to help someone with agitation or irritation, right? Because each of those things that I mentioned would have a different treatment. So I don't know if that's helpful, but that would be our approach for how we would think about it.
Oh, that was excellent. Well, thank you both. These have been excellent so far, and I'm really excited for this last one. We have Dr. Katie Bucklen with us. She's actually a retired pediatrician and got interested in mindfulness and all of these, non-medication therapies, I guess, to, work on these issues from working with her patients as a pediatrician. So I'm very excited to hear more about your talk as well. Should we go?
I am going to share my screen here first. There we go. How's that?
Excellent. Perfect.
Okay. I first would like to just say thank you very much for the invitation to come from Tanda Meehan and the team, and the opportunity to learn about more about Chiari now than what I learned when I was in pediatrics, because we didn't see a lot of Chiari 1. And so it wasn't something that I really stayed up to date on. And I think it's really impactful regarding the things that I teach with mindfulness. Last spring, we did a mindfulness for chronic pain class, and it was a pilot research study for what it felt like to be in a live group. And as with other people who are struggling with chronic pain, which very much like I imagine the symptomology of Chiari is something that's really importantly helped by having a group of people who are living through this similar experiences. And I'll also just mention that invisible illness is really something that's become important to me in my training as a mindfulness teacher. And I will share that I have an invisible illness myself, and I'm grateful for the work that's done in this way. So I thank you all for had the opportunity to fill in the surveys with the information about your experiences with mindfulness and your thoughts and your interests. It's really helpful to me to be able to speak to what your interests are, and I'll say that they're very broad, and there's folks who've not had any experience at all with it, and folks who've practiced routinely. And the thing that I'd like you to know is that this is a very different experience for everyone, and you kind of have to come to it on your own terms. So my intention is to share this with you enough that you can say, this is something that makes me curious. And if it's, or you could say, I'm for sure this is not for me. Or if you're somewhere in between, one day you'll remember this talk and maybe consider it. Let's see, I'm not sure if I can switch my slides on my own. There we go. Okay. So really what is mindfulness is it's a common question, because mindfulness is a human trait that we all have inherently, which is paying attention to the present moment experience. And the practice of mindfulness is teaching your brain to get better at paying attention. So it's like doing exercises, and we'll talk about kind of what that looks like. And when we do it, we want to work to pay attention to our attitude about it. So for example, if I walk outside, I'm not a hot, humid girl. When I walk outside and it's really hot and humid, I might label that as, oh man, this is terrible weather, right? So I'm judging the weather as terrible. And the other one is, the option would be to come outside and say, what is it that makes the air feel this way exactly? What is it that, like in particular in St. Louis, we get these stretches of it, and like, wow, it must be in the Mississippi River Valley. And like, how does it feel on my skin? Really? Is it that bad? Is it really that bad? Like, kind of. And then, so that's a kind of kind and compassionate curiosity. And the most important one as we go through the talk that I'd like to share is towards ourselves. So for me, it's sometimes I'm frustrated with the weather, and sometimes I'm frustrated with myself. But what we want to do with this practice and with mindfulness, attention building, is to remember that kindness and compassion towards ourselves builds as we use it, just like it builds as we use it on the weather. It builds as we use it for ourselves. So readjusting when we say, oh, I'm such an idiot, instead say, I could have done that better. That was not my best moment, right? So finding ways to really be kind and gentle to yourself, because I'm going to ask you here, because this is an experiential thing. Like, you can talk about mindfulness all you want, but it's just like talking about going to the gym. If you say, I'm going to get stronger, and you talk to your family about it every single day, you can imagine the likelihood of you getting stronger if you only talk about it. That's what mindfulness is like. So we're kind of bringing together the brain effort here to train our attention and to train how we notice what's going on. And it's a mind-body experience. So when I teach mindfulness, the way that I know how to teach is by how I feel inside. And that's taken me, I guess it's been 8 years that I've been practicing myself and then teaching. And what I've learned through my teacher trainings that I've gone through is that when we are aware of our physical selves, it delivers messages to us. And sometimes if you have an illness or you're not feeling well, it can feel like I really don't want that message. But sometimes it's informative. This is different somehow. But also we get messages of emotions that arise. For example, I will tell you that I did not know what anxiety felt like until I'd been practicing mindfulness for some time, and I had a sensation in my chest that made me feel a little bit uncomfortable and a little bit sick, and kind of wanting to do something. I wanted to act on it, but I really didn't know what it was from until I realized that I'd had a conversation with a good friend the day before that I thought didn't go well. And I was like, oh my gosh, this is anxiety about that conversation. So it was kind of like an eye opener for me in how this works. And over the years, those are the kinds of things that I've been able to bring into my life. I will tell you that it doesn't happen that you necessarily immediately feel these benefits. But I will tell you, my husband reported to me when I had been practicing for about a year that the tone of like how we lived in our house had totally changed since I started doing this business. And I didn't think that I was any different. So it's not a quick fix. It's not a high yield deal in the immediate sense. But the good news is it's actually really relaxing. So that's why would we do this if it takes so long to develop it? It's because initially when you start to do it, you begin to notice things that are happening in your mind that are kind of curious and interesting. And sometimes they're frustrating, but like you might be repeating a thought, like the grocery list over and over again when you're trying to practice mindfulness. That could be annoying. Your default mode network will show itself to you when you stop to notice it. And, that can be a little frustrating. But usually the practice is pleasant and relaxing. And now I'll just share that I would like to do a little bit of practice, like I said, and I want you to know that if this feels uncomfortable to you in any way, I encourage you to moderate what you're doing. You don't have to do everything that I say, and to have your eyes open and to get up and to move around if you're able, or to move within your seat. Movement and having your eyes open, and then seeing if you can follow with some more comfort. So the first practice that I like to do is called an arrival practice. And it's basically taking stock of what's the present moment for you right now. And for each of us, we can start with noticing how we're sitting. And what we want to do is kind of have an open, upright posture that's dignified. I'm not sure exactly why this is. For all the neuroscience people I've pestered about it, it seems to be more accessible to relax when you aren't crossed over, if you can uncross, if that's available to you. So to sit up in a dignified manner to the best of your ability as is comfortable for you, and modifying as you need to, take a moment to use your strongest sense, which is your vision, and look around where you are in the room that you're in, and see if you can notice 2 or 3 different qualities of things, like something maybe that you haven't really even noticed that was on your desk that's been there maybe for weeks, or something in the room that you haven't noticed for a very long time. And then see if you can see something that you find pleasant to look at. That's maybe surprising, like it's kind of mundane usually, but you know what? Actually, that's kind of nice. And notice that there's a quality to almost everything. Some's unpleasant. Oh, that one's unpleasant. That's something I need to deal with. And there's a connotation that goes with it. And then if you feel comfortable, you can soften your gaze just down in front of you, away from the screen, preferably. If you want, you can turn to the side. And you can also close your eyes if that's better for you. And now turn your attention to the sounds that you can hear inside the room, maybe outside. And during this practice so far, you might have noticed that your mind has wandered and you're thinking about something else. And that's what minds do all the time. It's totally normal. What we want to do is say, I'm going to take my attention now back to the sounds in the room. And that's your first weightlifting right there. It's asking your mind to focus on the sounds in the room. Now turn your attention to the sensation of support that you feel. You might notice it with your feet on the ground or the chair that's holding you up, or where your hands are resting. Choose one and allow your attention to rest there. And again, if your mind has wandered, imagine that your mind is like a little tiny puppy and you're teaching it to sit and stay. And you say, stay, mind, stay, with a kind and gentle tone. And now turn your attention to your breath, the feeling of the breath going in and out of your body. You can choose where or what part of your breath you'd like to put your attention on. It could be the rise and fall of your chest or belly. Or maybe the tickling of the air on your upper lip when it moves through your nostrils. You don't have to do anything to change how you're breathing. There's no right way or wrong way. But just noticing it. And you might pause to wonder at the fact that it's always there. We are always breathing, barring some severe event, unexpected, I hope. And yet we hardly ever notice it. And it's there for us, and it keeps us well. So now when you're ready, you can wiggle your fingers and toes, and maybe notice one more time how your feet feel on the ground. And then gradually open your eyes and look back around in the room that you're in. So I hope, I don't know if you can raise hands, but you can raise your hands if you've noticed your mind wandering. Yes, okay. Yeah, so congratulations. That's excellent observing. And it's strength building every time you notice. And so I teach students at St. Louis University and several group sessions at WashU on the undergrad campus. And the young folks tend to be kind of hard on themselves, that they're not getting it right. And seniors do too. I teach seniors as well. But the most important thing is to try, if you mess up, start again and don't lose hope. And then this practice that we just did, it includes attending to our bodies, like noticing how our body feels in a very kind of gentle and peripheral way. It doesn't have to be all the time the same thing. And it can also be movement. So we can do mindful walking, or you can do walking meditation, which is very serious and very slow, where you're very focused on your feet on the ground. And where mindful walking could be, you're out in your neighborhood and you notice that the leaves are beginning to turn and you see how many yellow leaves you see, and you wonder when the rest are going to turn. And I had a student who was actually WashU faculty who started his mindfulness practice independently, and he didn't like to sit for meditation. So for about 2 years, he did walking meditation. And when he started taking my class, I very cautiously suggested that it might be nice to try formal meditation again. And he said, okay, I'll try. And that guy was meditating for 45 minutes to an hour and a half every single day in about 3 weeks. So what I want you to know is that informal mindfulness activity is just as valid at helping us to achieve this state where we can begin to really settle our minds and attend to present moment, even if we're not doing serious mindfulness. You don't have to have a proper place, and you don't need a candle that's like, you don't need music, and you don't need an app or someone to guide you, but you can, and it can be very supportive. When we become aware of our bodies, this becomes very helpful with invisible illness like chronic pain. And I'll use that as an example, since that's what I worked with in my last course, but I understand that it's also prevalent in Chiari. So I will say that the practice doesn't necessarily change what happens, but I had the privilege of working with the pain team at St. Louis Children's Hospital for many years. And I learned a lot about the fact that pain occurs not just because of a physical area that's been injured, but it's because of activity in the brain. And so we can actually begin with this process like I just did, where we're being kind and compassionate to ourselves and observing what's going on in our bodies. We can begin the process of starting to feel a little bit more in relationship with ourselves. I will share with you that I had chronic pain, and I worked on it quite a bit before we did the class. And for years, I'd been trying to use mindfulness to get rid of my hip pain. And it went away during the chronic pain class. And it was because I really started doing it with more intentionality than with a desire to get rid of the pain. And that's one of the premises of mindfulness, is that we try not to make it a striving towards a specific goal. So we want to not hold on to a specific outcome when we do the practice. We want to do each practice for its own sake and to take what comes with it. But the teaching for pain, I will share you, is to turn your attention to rest on the pain. You can start with something easier like exposure therapy. For example, if you're sitting in practice and you get an itch, to just notice how it really feels and to try not to scratch it, and then scratch it when you need to. And that's just a little bit of kind of how to do that. It takes, most of my students who've had a specific discomfort that took mindfulness training classes found the specific directed work to be incredibly challenging. And I think it's a biopsychosocial combination of things that go on for us when we are living and struggling with our bodies sort of changing in how they function, unpredictable, and sometimes taking away from us things that we would like to do, sharing, changing relationships. All of those things are so fraught that it's sometimes easier to just practice mindfulness and then to gradually begin to go towards the things that are most challenging when you feel strong, when you feel like I've been doing this for a while, maybe with a teacher or taking a course, that kind of thing. So the things that we know for sure according to like long-standing research now, initially predominantly functional MRI with Buddhist monks sent by the Dalai Lama to sit in functional MRI scanners at the University of Wisconsin. And it showed things like that the average, like of what the average lifelong meditator can do in a functional MRI, which is really cool. And the funniest one, which makes me feel really good about my wandering mind, which is that for the average experienced meditator, they can their mind doesn't wander for on average 4 seconds. So none of us do this well. Like most of us wander but in less than a second. So, but they make it for 4. So they're really good at this. So it's really not about not thinking. It's about knowing what you're thinking about and recognizing how you feel about it. So that when you say, like, that's where the emotional regulation comes in. Say or someone's being really down on themselves because their body's not functioning the way they want it to. To recognize that you're doing that is exceptionally helpful. To be able to say, maybe I should ask for some help. What can I do that cheers me up? And have your resources available. This is like, I'm not, it's kind of embarrassing to be in front of a neurosurgeon and neuroscientist, but I'm not that. But the way that I kind of think about this in a very broad sense is that when you get stressed, you're in the limbic system or your amygdala, right? And the amygdala, I learned, and you guys can correct me if I'm wrong, but it doesn't really mature beyond the age of 3. It's like having a little 3-year-old in your brain, and they're very good at detecting danger. And so they're really reactive and they need a little moderation. So the prefrontal cortex is your higher order thinking. So it's the thing that 16-year-olds don't have when they learn to drive, but they get it about the time they're 24 years old, is it begins to really develop and you can anticipate the consequences of your action better. So what happens with the prefrontal cortex is that it kind of sits in the back seat when we're living in a state of anxiety, a state of stress. And what the muscle that we're building is, I call it going from like a gritty path with a bunch of branches in it to get from the limbic system to the prefrontal cortex, where you can begin to intentionally ask yourself to take that super highway to the prefrontal cortex. So depending on how severe the anxiety or stress is, your capacity to do that can wax and wane, but it is much, much more accessible when you start practicing routinely. In fact, if I practice in the morning as opposed to at night, I'm much better at noticing, observing, and then actually asking myself, hey, is this really a feeling that I need to act on? Or is this just a suggestion? And maybe I should maybe I should consider that for a while. So say like when I was worried about my relationship with my friend, I wasn't doing anything about it because I was paralyzed by this feeling, which turned out to be anxiety. And then after noticing what it was and observing it, I thought, well, maybe I should call her, see how she's doing. And I did, and everything was fine. So I think that's a really, really simple scenario, but I think that what I've learned over the years is it's really becoming a habit over time for all of us to be able to practice in this way. So dedicating time to it can be really pleasant, but it's still doing work that helps you address the stuff that's more unpleasant. I'm going to ask questions, but I'm not going to. So I'm going to just put this poem up. Because I want to do another practice, which is called belly breathing before we finish. So belly breathing is an intentional slow things down that we can do sitting in a chair, but it's lovely to do lying down at home if you wish. And that is to sit back kind of in your chair if you're comfortable doing that, and see if you can relax your belly and put your hand on your chest and your belly. Put one hand on your chest and one hand on your belly. And now just as you're breathing, observe the feeling of your breath rising and falling. And notice which hand rises more, the one that's on your chest or the one that's on your belly. What I'd like you to try to do, if you're comfortable with it, if it works for you, is to push your breath in so that your belly comes out. So the breath is usually a little deeper, and that pushes the diaphragm down, which is what pushes the belly out. Some of us are native chest breathers, so it's not always really quickly accessible. So if it's not working for you, that's okay. Just rest if you need to, and then give it another try. If you'd like, you can soften your gaze or close your eyes. And really turn your attention to focus your attention on the feeling of your hand on your belly, rising and falling with your breath. So when we breathe more deeply down into the belly, the diaphragm goes down, which inherently switches your nervous system into the parasympathetic mode, which is your rest and relax mode, which then overrides the sympathetic nervous system. So just working on this and allowing yourself to rest and intently focusing on the rising and falling of your hands. And listening to your body about what's the right choice for you. If your mind should wander, gently bring it back, remembering that cute little puppy. Stay, mind. Stay. All right, so continue for 2 or 3 more breaths. And then when you're ready, you can again begin to move your fingers and toes and wiggle your body if you wish. And open your eyes and return. So this practice, it has kind of a 2-mode mechanism in addition to the diaphragm movement, aiding us towards a kind of more relaxed neurologic system in the moment, is the focusing on a discrete item. So the first practice we did, we went through kind of different things and moved around. And this one, there was a more intense focus, and it was goal-oriented. So it turns out we also do better with handling stress and anxiety when we can focus intently. It moves where the activity of the brain is from the more primitive centers of the brain up into the higher order centers. And that begins us to become interested in, well, which hand is going up and down? Why does this work for me? Or why isn't this working for me? Why does my body like to breathe into my chest? Which is totally normal. And I encourage you to practice again if you want to try. But to really observe that and wonder about it is one of the things that sort of turns off worrying. It's what a lot of people say is that curiosity is a superpower. So we can't expect ourselves. I'd like to share the dog book, although you may have already read it, but I have to move my thing so I can see all the words and say it right. If you can start the day without caffeine, if you can be cheerful, ignoring aches and pains, if you can resist complaining and boring people with your troubles, if you can eat the same food every day and be grateful for it, if you can understand when a loved one's too busy to give you time, if you can overlook when people are taking things out on you when, through no fault of your own, something goes wrong, if you can take criticism and blame without resentment, if you can face the world without lies and deceit, if you can conquer tension without medical help, if you can relax without liquor, if you can sleep without the aid of drugs, if you can do all these things, then you are probably a dog. So I love this poem because I think it truly reflects the mindset of mindfulness, which is this kind of puppy dog way of being. So, thank you, Tasha. Let's see, so I wanted to give you guys some resources because this is a process. The research has shown over the years that 6 to 8 weeks for adults is what it takes for our minds to begin to help us. They help us remember the mindfulness part. I totally started and quit so many times. And then after I finally did it enough times, my brain would say, you should meditate, or I want to meditate. And it's a really lovely transition, but it does take some time. So the timer, or the app that I use, is the Insight Timer because it's free. And that's the one I recommend, all the free ones. So waking up is not free, but it's a really in-depth look at kind of what happens in our minds. It's not just mindfulness, it's meditations of all kind. Calm is one that a lot of my students have used. I personally haven't gone there because I've been so happy with Insight Timer, and Headspace is similar as well. Once you get a timer, there's a whole bunch of things to choose from. If you look at that and your brain just goes, no, that's just too much, I can't decide, shoot me an email. And I'll just send you a couple that are short and good, and you can try them out. I used to drive home from Children's to my house, which was 3 miles, and I would do a 5-minute meditation with my eyes open, driving. And I still walked in the door and looked at my house and my kids and my husband, like seeing them. Whereas before, I'd come home and all I was seeing was what was going on in my head about all the patients and what was going on at the workday. So transitioning back and forth, however you can swing it, no perfection required. I do want to mention that there is an app for anxiety that was created by Jed Brewer, who was formerly at WashU, called Unwinding Anxiety, and it is not free. But you can do it for a couple of weeks and see if you're interested. The first thing that I got out of that was like I was at a talk that he gave, and he talked about this, focusing on where you feel anxiety. Where do you feel in your body? And then which side of your body do you feel it on more? So that's really narrowing in. And he describes a lot of success with his clients with pretty significant phobias and challenging lifestyle stuff. It's mostly adult related. So I don't know for sure what there is for younger people. I do think that the college age kids that I teach have more neuroplasticity than I do. So they pick it up faster. And I think kids would too, but I don't know how fun it would be, like if it was a younger than college age person. You could take a class. There's a lot of introductory courses and mindfulness-based stress reduction courses. And then you can search for local and online mindfulness and meditation groups. I have now 3 mindfulness groups that I hang out with. They live all over the country, and I know we visit each other. We go to each other's houses. It's hard to find at first, but again, those are things that I can help if you're at all interested. So, and then like I said at the beginning, if you don't do the mindfulness, you won't become more mindful. So you can read about it all you want, which I did. I tried it. It doesn't work, but it informed me a lot. So I may be a better teacher because of it. But the 2 books that are listed, there is one for teens, which is the Chronic Pain and Illness Workbook for Teens by Rachel Zofnas. And it's a workbook. So you're using CBT, I almost said CBD, CBT and mindfulness in the workbook. So it's kind of supportive. And then there's some stuff online that they have that you can listen to. So here's their website, and then my email. So I really, really appreciate the chance to talk with you guys, and I'd love to hear what your questions are.
Amazing.
If you have any.
Thank you so much, Dr. Bucklen. We do actually have some really pointed questions. I want to get to them. So thank you. You mentioned the walking meditation and, feeling the floor. There's a really practical question here. Some patients are in power chairs, they can't walk. So how does someone in a chair do that? Is it the same concept? How would you coach them through that?
Oh, I'm so glad you asked. I apologize for not mentioning it. The mindful movement of any type can be used. So, like, for example, if you have a chair yoga that you can do, that's a wonderful mindfulness practice with the intention of really focusing in one or two areas. So you can move, like, say you're doing movements with your hands, and you notice how that feels while you're doing that. And then you move to different zones. You can also stick with your breath. I took care of patients who were often on the lung transplant waiting list. So we did not do breath and we did a lot of other things. You can also, so any movement that's not like going to make this an unpleasant experience can be used for mindful movement. There's the recommendations would have to be kind of interpersonal, like pretty clear. Because like I actually caused myself trouble doing like the easiest yoga on the planet. So it's really good to get somebody who helps you out with knowing what's safe for you to do and but the first measure is what feels right, what feels good. That answer the question?
Sure. Do you have any practical tips, I guess, to how to be mindful in that position?
In the chair?
Yeah,
Well, I
yeah.
think if you're mobile, like, so if you wanted to move, like if you had a space where you could go back and forth in the chair and you spent your time doing like we did at the introduction, just noticing what you see, you could do that. You could also do like depending on the mobility of your upper body, you could do upper body shoulder shrugging and rolls. Steer clear of the neck would be my recommendation. If arms are available, we could do up and down, and you do them like very slowly and feel the sensation of the air on your skin. If you're outside or you're sitting outside, you can notice the sensation of the wind on your body while you're doing these activities to just kind of enhance like your present moment awareness.
Amazing. So I'm going to combine these two questions. So we've heard that patients, particularly with pain, and you have experience, so when they do like body scans or any kind of mindfulness, they notice that it brings almost too much attention to the
Yeah.
pain that they're already experiencing. So how do you coach people through that? Is that an anxiety response in the first place?
It could be exciting, and it could also be like a trauma relationship where you can't turn your attention to a place. And that's why like when I talked at the beginning about honing your attention and choose something like an itch, not that like do that first. So then if your mind bounces out of it, that is a thing. And that's your mind saying, not right now. And that's something that you can, I would say, if you wanted to approach it and try to get to that place, coaching would be helpful. So like at the Center for Mindfulness and CBT, they're all therapists who use mindfulness and or CBT. So finding a therapist in that vein who is knowledgeable about those things might be able to help best in that setting. But the idea would be to move away from the area that's most troublesome when you go to do the practice. It turns out a lot of people do body scans, but they're also triggering for a lot of people. So in my teaching, I no longer do the body scan, like until we've had it like 6 classes. And then I know, I know all the students and they feel, or the participants, and they know that that they can come to me if there's something that's going on, because there's a lot of shame and worry about when we have a relationship with our body that's always in evolution. I would say it's something that can be hard to ask for help on. So but it's I would say, like, if you do body scans and you enjoy them, and you can skip the area and do it well, keep going. But if you are trying new things, body scans might not be the first starting place that I would recommend. And the mindful movement should be something, like I said, that you enjoy, depending on your own circumstance, not something that you're forcing in any way.
And then final question here. So these are excellent tools to use. So applying this to maybe an upcoming procedure or some kind of medical intervention and even interaction, frankly, can you apply this to getting ready for that kind of an event, especially in particular if that past history, particularly in the medical space, has been a little bit painful?
Yeah. So what I have found is that practicing in the morning of or the night before, depending on how early, and then letting people know that you have worries about it, because it's kind of outing yourself that begins to allow you to notice where you feel it. So it's not, because we have a natural aversion to uncomfortable situations, that we push the feelings away and we want to just be strong. And so it's kind of a gentle way to just be like, this is something that's uncomfortable for me, like however you want to put it. And then I have done the belly breathing exercise in the MRI scanner, and I do it every time I go, because I have terrible claustrophobia. And so it's not as strong an anxiety, I think, as what others may face. But it's one of the things to do is, before you go in, if you have someone bringing you in and if you're walking independently or on your own, this is harder to do, but is to close your eyes. Like if you're in a wheelchair and you're being wheeled in, close your eyes and turn your attention inward before you get into this setting. Begin to notice how your body is, and then that deep belly breathing and the gentle in and out, practicing it as much as you can beforehand with something that's comforting to you. So I have this blanket that I took on a 7-day silent retreat and I meditated with that blanket because I was freezing all the time. And I see that blanket and it makes me smile. So if you can find something that's comforting to you that you can take with you as well. So usually I try to teach, it's helpful to practice without any needing to any supplies, any in particular. But for situations like that, like if you could meditate, like I lay down a lot to meditate. I'll lay down under that blanket, and then I didn't ever take it to the scanner, but I seriously considered it. So if you could get something small or something you feel comfortable taking with you, or having it be the one that you take, and just say, it's really cold in the hospital. It's always really cold in the hospital. So nobody's going to look at you twice or think that you're being a wimp if you have something that's comforting, like a blanket or a jacket, or I don't know.
That's a really good point. I mean, I don't have any more questions. I'm not seeing any more in the chat. I want to thank everyone, and I don't know if Dorothy, if you want to come back on, or Tanda, any of the presenters want to say anything before we say goodbye and good night, or go ahead.
I just want to say thank you so much to all the presenters. Like, it was awesome. I have a dog barking here, so I was reluctant to turn on my microphones. Tanda, thank you for everything. Thank you to WashU, thanks to the presenters. It's been awesome.
Great, and these will be posted on both the Bobby Jones website as well as the WashU Chiari website as soon as we've had a chance to edit them. So thank you all to all of you who are attending and spending so much time with us.
Thanks all. Good night.